Hello, so this is part 3 out of the 3-part congenital heart disease teach. So if you want to see part 1 and part 2, click those videos first before you come to this part, which is the last one. If you want to see any of the other lectures that my colleagues are producing, then do click on any of the other videos of this channel. Please like and subscribe to the Medics.Academy YouTube channel to get notified about future videos as our content is consistently updated. And if you're a medical student, sign up to the free SDocs program, which you can do so from the link in the description below. So now on to the last part, which is all just some clinical cases for you to apply the knowledge you've learned from part 1 and part 2. So the first case, case 1, a baby is born with obvious signs of cyanosis and distress that do not improve with oxygenation. You find out that the mother missed her 20-week fetal anomaly scan. What do you do first? So just kind of breaking down this case, you know that because the baby is immediately born with cyanosis and distress, that it's likely to be a right to left shunt. And because the mother missed her 20-week fetal anomaly scan, you know it's likely something that could have been diagnosed prenatally, but wasn't because she missed her screening. So she's probably coming with an undiagnosed congenital heart disease. So what you would want to do first is something that you can do immediately, regardless of what hospital the lady was born in, or even if it's in more of a community setting, which is prostaglandin. So you want to give prostaglandins immediately because especially if this baby has a transposition of the great arteries, prostaglandins could be the only thing to keep them alive because it will keep that duct between the arterial system and the pulmonary system open so that they're able to have some oxygenated blood going to the rest of their body. So your answer would be first, give them prostaglandins just to give them time, and then you want to do an echo immediately to get a definitive diagnosis before then looking at surgery. Okay, so this is a continuation of that same case. So you give your prostaglandins first, then you perform an echo, and on echo you see parallel great vessels. So the question is, what operation is this baby likely to receive and when? So parallel great vessels is a sign of a transposition, so transposition of the great arteries. And so the operation that this baby will need is an arterial switch procedure. And these occur in the first week of life. So basically, as soon as you can do the procedure, you tend to just do it. And that's because these babies just won't do well before getting this procedure done. Okay, so now on to case 2. So a 6-month-old baby is well and thriving and is visiting their GP for a routine check. The GP detects a quiet systolic murmur over the pulmonary area of the chest. What is the most likely diagnosis? So this is quite different from the previous case because this baby is completely asymptomatic and is well and thriving, but the only sign is a quiet murmur over the pulmonary area of the chest. And so this is actually an atrial septal defect or an ASD. So this is a left to right shunt instead of a right to left shunt. And that is why the baby is presenting asymptomatically and the only sign is the murmur. And just remember how an ASD differs from a VSD and that a VSD would have a harsh sounding systolic murmur, whereas an ASD has a more quiet murmur over the pulmonary area of the chest. So now the last case, which is case 3, a 2-year-old child is brought by a worried mom. The mom says she feels like the child's legs are always cold and the child is refusing to walk. What signs would you expect to find on investigation? So this one is actually a bit tricky, but the main kind of hint is that the child is refusing to walk and the child's legs are cold. Those are kind of 2 signs that the child's lower body might not be getting enough blood. So one thing you'd want to at least have on your differential list is a coarctation of the aorta. So for signs that you would expect to find on investigation, you would have a brachiofemoral delay, again, just feeling that brachial pulse, comparing it to the femoral pulse. And you would also find hypertension in the arms and hypotension in the legs. So that is the end of the congenital heart disease teach. These are my sources, and I want to thank all these resources for allowing me to put together this presentation. And these are the sources of the photos used in the presentation as well. So yeah, thank you for listening.